Mod Pizza. Again, there is one in Brighton, right off 96, sort of off 96. Hello, everyone. Thanks for joining us today. Today we have an amazing speaker coming all the way from U of M down in Ann Arbor, Dr. Brock Humphreys. Dr. Humphreys is a postdoctoral research fellow with the Department of Radiology at the University of Michigan. He is bringing us lots of great information today. And at the end of Dr. Humphreys' presentation, if you would like to ask any questions, please email myself at Jennifer, Jennifer, .Follett, that's F as in Frank, OLLETT, at mcc.edu, or Becky Gail Gonzalez at Rebecca, REBECCA, Gale, GALE, at mcc.edu. Thank you for sending in your questions. Dr. Humphreys, it's your turn.
Hello. I can't see my presentation, but there it is. Okay. I am a postdoctoral research fellow at the University of Michigan. And today I'm going to talk to you a little bit about my work, but I also, before I get into that, I would like to talk to you about some of the advancements that we've made in cancer research over this last decade. Next slide, please. Before I get into all of the data and stuff, I wanted to start out with saying that cancer is not a new disease. For instance, the Edmonds-Smith papyrus, which dates back to 3000 BC, so about 5,000 years ago, this medical text, this Egyptian medical text, actually describes breast cancer in it. And the writer of this papyrus actually said that the mass in the breast was a grave disease and that they didn't know how to treat it, that it was untreatable at that time. Next slide. Since the Edmonds-Smith papyrus, though, we've put a lot of research into it and we have a better understanding of cancer. And because of this, we have statistics on cancer and can track cancer over the last couple hundred years or 100 years. As you can see from this slide here, in general, male and female cancer incidence rates since 1975, about 40 years ago, has gradually increased, while mortality in males and females has gradually decreased over the same time. Press next, please. If you separate these incidence rates into male and female populations, you can see that some cancers, such as lung and colon in the male, have decreased, as well as colon in the female has decreased. But some cancers have actually increased in their incidence. In the male's prostate and melanoma, and in the female's breast and melanoma as well. Next slide, please. If we focus on death rates, cancer death rates over the same amount of time, we can see that we've actually decreased the cancer death rate over the same amount of time. The blue line is the actual death rate, and the red line was the projected. So since early 2000s, late 1990s, we've actually saved about almost 2 million or over 2 million lives because of all the work that we put into it. Next slide, please. Or next, thank you. Particularly focusing on some of these cancer death rates and all of the cancers, you can see in general, almost every cancer has a higher survival rate now in the early or in the mid 2010s compared to where it was in the 1970s. If you want to particularly focus on all cancers, you see that cancer death goes from 50%, or sorry, cancer survival goes from 50% all the way up to 67%. And one that I like to particularly focus, because that's what I work on, if you look at the breast, in the 1970s, the survival rate was about 75%, but now we're almost at 90 and even above 90 now, based on the new statistics. So we put a lot of work in and we've saved a lot of lives. Next slide, please. So what does this mean for the population? Well, if we look at 100 people in the population, in general, about 89, almost 90% of these people will be over the age of 50 who are diagnosed with cancer. And then the other 11 are under the age of 50. So it's much more common in older people. Next slide, please. Or next, please. If you look at, in particular, at the young adults or the children, over a 5-year span in the mid 2010, so 2013 to 2017 or 2012 to 2016, we can see that we have increased the incident rates. So the occurrence of cancer has gone up 1% each year, but we've also decreased the death rate about 1 or over 1% each year over the same time. So in general, we're getting more cancer as time goes on, but we're getting a decreased or increased survival rate or decreased death rate. Next slide, please. So why is this? Why are we getting higher increase of cancer incidence for some of these cancers? Again, not all, but some. Well, and this, as I mentioned in the previous slide, has a lot to do with the increased lifespan that we have now. So that is the single biggest contributor to cancer. So for instance, back in the early 20th century, in the early 1900s, we were not living to be as long as we are now. The average lifespan was maybe 30 years. Well, now our average lifespan is over 70 years old. And cancer is essentially a addition of a bunch of mutations in your DNA. And eventually all those additions lead to a cell. All those mutations in a cell can lead to cancer. And yes, your cell has the ability to repair these mutations. However, as the older you get, the less efficient these are, which can lead to higher chances of cancer. In addition to the increased age, your lifestyle plays a really large role in cancer incidence. We know that now, because of research that we've put in the early 2000s and the early 2010s, that obesity and diet play a huge role into cancer incidence. We know, for instance, processed foods can lead to cancer, as well as an increased consumption of red meat can lead to higher rates of cancer. But not only food, but if we think about sunbathing or going in a sun lamp, or these things can lead to increased rates of melanoma. And then one of the biggest factors is smoking. We know that smoking leads to a higher rate of lung cancer in individuals. And I think that is why, at least now, there's a huge push to try and stop smoking. Excuse me. But one thing that I don't think gets enough attention is the fact that we, because of all the research and the money and the time that we've put into studying cancer, we're actually better at detecting cancer now. We can detect it earlier, we can detect it smaller, and we have been shown to be able to treat it better because we can detect it earlier. So things such as a mammogram, we're better able to detect a abnormal breast based on a mammogram than we were 10 years ago. And also the prostate-specific antigen. This is a test that men can take, and it actually will detect prostate cancer before many imaging machines can actually detect it. So because we put all this work into it, we're actually better at detecting these cancers, which means we detect it earlier and we can save patients' lives. And it leads to the increase in cancer incidence rates that we're seeing. Next slide, please. So now I kind of want to switch gears a little bit and talk about 6 areas that I think we've made huge strides in this decade, this current decade that we're in, or sorry, last decade, because now we're in the next decade. But so through 2010 to 2019. And the first one that I wanted to talk about was cancer immunotherapy. So before the 2000s, we really didn't think about harnessing the immune system in order to treat cancer. But recent research, and actually the ACS has funded a lot of this research, especially this research leading into this technique I'm calling Chimera here, or Kymria, What they've done here is they've taken natural immune cells from the patient's body who has cancer. They'll take them out of the body. They will reprogram them so that they target cancer. They'll inject them back into the patient, and then those immune cells will attack the patient's cancer. And this is really effective, and it's really novel. And I think it's quite an amazing technology, and ACS has been instrumental in moving this forward. Next, please. The next thing that in the cancer immunotherapy section is something called PD-1. PD-1 actually is a therapy that is pretty commonly used in the clinic now since it's been approved this decade. But what it does is tumor cells are actually pretty amazing in that they're very good at avoiding our immune cells. So what an immune cell will do is it will go up to a tumor cell, it will recognize it's a tumor cell, and then it will kill it. However, tumor cells can use certain receptors on their surface that will target the T cell or the immune cell and stop it from killing it. So they're avoiding essentially our immune system. But we developed a drug called PD-1, and it blocks this receptor on the tumor cell, which then allows the immune cell to attack and kill the tumor cell. So it's pretty amazing stuff, and it's actually, like I said, being used a lot in the clinic, and it's being, at least in a lot of clinical trials that I'm seeing now, this drug is actually being used in combination with a lot of normal therapies that we've been using. Next slide, please. The next thing that I want to talk about is precision medicine. So precision medicine is, we'll take the clinic right now. If we just treat every person that comes into a clinic the same way, it's not going to work on every patient. It's only going to work on a very small subset of those patients. So what precision medicine is it takes every person, treats them as an individual, and devises a treatment plan specific for that person. So just like each person is unique in themselves, each cancer for that person is unique. And we need to understand what makes it tick. And then once we understand what makes it tick, we can devise a treatment plan to treat that patient. And it's much more effective than the chemotherapy or any standard therapy that we used to use. So this is really advanced in the 2010s in this decade. And I think it's going to be a huge part of the clinic as we move forward. Next slide. Another thing we've actually learned, this is a very busy slide, and I'm so sorry if you're looking at this and getting confused. But what we've, in addition to looking at the immune cells, we've also found that there are other cells in the body that help the cancer form and help a tumor form and help the cancer progress. And another one of these cells is the fibroblast. Now, a fibroblast is a cell that you would typically see, or what typically it does is it closes wounds. So if you cut yourself and you start bleeding, what these fibroblasts do is they start the wound healing process. So they'll close the wound, stop the bleeding, that kind of stuff. But what we found this decade is that these cells actually talk with the cancer cell, and the cancer cell talks with these cells in order to promote cancer. And we've only just begun, but at least we're making progress into defining these processes, developing targets, and stopping this connection between these two. And I think this is also very promising for the future. Next slide, please. The fourth one that I want to talk about is the microbiome. So you might see on TV, you might see in magazines, probiotics, that kind of stuff. So things that are meant to help regulate the gut microbiome, so the bacteria that are sitting in your stomach. And what we found in this decade is the fact that this microbiome, or the bacteria in your stomach, are critical for almost every process in your body. They have an effect on almost every process, and cancer is not left out of this. So actually, your bacteria in your gut can actually drive cancer. And we've found out this decade how that happens. It happens through an inflammatory response, and then how we can actually treat that by probiotics or other things that target these signals, and we can actually prevent cancer or at least reduce cancer incidence in these cases. Next slide, please. The next one I want to talk about is epigenetics. So if we think about a movie set, the cell is the actor, the DNA is the script, and epigenetics are the director. So the cell is acting and performing exactly how the script tells it to, but the director, or epigenetics in this case, can actually change the script in order to change how the actor acts and how the cell responds to certain things. In terms of cancer, epigenetics is critical because what it can do is it can actually turn off tumor suppressors, or it can turn on oncogenes. So epigenetics can directly affect cancer formation. But what we've actually been able to do this decade is develop inhibitors that target these things and actually reverse this process so that we turn the tumor suppressors on and we turn off the oncogenes. And I think there are a bunch of clinical trials going on that directly look at this. And I think this is since it just started this decade, I think it's going to be a very helpful place of research for the upcoming decades as well. Next slide, please. And the last thing I wanted to talk about in terms of the advancements that we've made over this decade is in health equity. So health equity is just the ability for everyone to have fair and just opportunity to treat and survive their cancer. And what work at the ACS has done, as well as other people, they found that people who are from poor places are actually more likely to succumb to cancer than people who are from more affluent areas, which is that's not right. So I think that there's huge strides, at least this decade, to kind of to address this because it's a big problem. And one of these opportunities I want to talk about is the Cancer Action Network through the ACS. I'm actually a member of it, but they fight for this. And they really try to make sure that patients have the treatment that they need in order to survive cancer. So not only do they provide rides to people who may not be able to have rides to go to these treatments, but they also give them the opportunity to get the top quality and best treatments for their cancer. Next slide, please. So now I want to switch gears a little bit, actually a lot of it, and talk about my work. So before I get into that, I want to say that I am a ACS funded researcher. So the work that I do has been directly funded by the ACS. So people who have fundraised for the ACS have directly contributed to this work. And I wanted to say thank you to you, because if it wasn't for you guys doing what you do, I wouldn't be able to do what I do and I love what I do. So I really wanted from the bottom of my heart to thank you for giving me the opportunity to do this. And I wanted to thank the ACS for believing in me as well, because not many people believe in a startup person, but the ACS did, and I really appreciate it. So my work focuses on breast cancer and understanding how breast cancer works in order to develop new therapies to target the triple-negative breast cancer. Next slide, please. So before I get into that, I want to start with the estimated cancer rates and deaths for 2020. So almost above 900,000 or more than 900,000 new cancer cases are what they're estimating in 2020 for females alone. And about 30% of these are going to be breast cancer. The ACS also estimates that about 15% of all cancer-related deaths in females are going to be due to breast cancer this year alone. And in general, this rises each year, which is not good, and we need to fix that. So that's why I study breast cancer. Next slide, please. So there are 3 subtypes of breast cancer. We have luminal, which is defined by expressing the estrogen receptor or hormone, common type of breast cancer. Excuse me. And occurs about 70% of all breast cancer cases are luminal. The next subtype of breast cancer is the HER2, and that's defined by expressing the HER2 receptor. And it makes up about 10% of all breast cancer cases. And the last subtype is triple negative, which is the subtype that I study, and that does not express any of the hormone receptors or the HER2 receptor. And makes up about 20% of all breast cancer cases. So triple negative actually has the worst survival rate of any of the subtypes of breast cancer, and that's because the luminal and HER2 actually have targeted therapy. So we can actually, because they express the hormone receptors and the HER2 receptor, we can have drugs that target those and directly kill these cancer cells, leaving the normal cells fine. However, in triple negative, since they don't express any of those receptors, we can't use any of these therapies. So we actually have to use standard chemotherapy, which does not discriminate between normal cells and cancer cells. And because of that, you see people who are under chemotherapy, they'll not only be treated for cancer, but they'll lose their hair, unlike me, who's just losing it because I'm getting old and stressed out, or they will have no appetite, things like that, because these chemotherapies do not discriminate between a normal cell and a cancer cell. So the goal of my work is to study triple negative and try and develop these targeted therapies for this subtype of breast cancer. Not only is triple negative worse because it doesn't have these targeted therapies, but triple negative is inherently more aggressive than the other subtypes. They're more migratory and more metastatic than the other types of breast cancer. Next slide. And what I mean by metastasis is it's a very complex process by which a cell from the primary tumor moves away from that tumor and forms a secondary or metastatic tumor at a different site. For instance, for breast cancer, the most common sites of metastasis are the brain, the lung, the bone, and the liver. So these are the spots where you typically see metastatic breast cancer. As you can see from this diagram, one of the most important processes or characteristics that a cancer cell must have in order to metastasize is to migrate. They need to move. If they can't move, then you have a better prognosis because you only have to treat one spot. If it moves away, that's when it becomes more difficult. And that's what I'm trying to study and to try and stop, is these cancer cells from moving, to make it easier for the doctor to treat the patient and make that cancer go away. Next slide, please. In my title, I talk about a particular set of cells called tumor-initiating cells, or TICs. And these are a very small subpopulation of the tumor. So they make up about 1% of the entire tumor. So it's not a lot of these cells within the tumor. However, even though there's a small number of them, they actually drive tumor initiation, progression, and metastasis. And that is because of the properties that define what a tumor-initiating cell is. So these tumor-initiating cells are defined by essentially an unlimited ability to divide, to grow. They're not immortal, but they can grow under any circumstances, and which makes it difficult to treat them because they'll just keep growing. These tumor-initiating cells are also chemoresistant. So the standard chemotherapy will kill the rest of the tumor, but it won't kill these cells. And then these cells, based on their name, can form a tumor. They are the reason why cancer comes back. So if you ever have heard anyone that has recurrent cancer, it's more than likely due to the inability of them to treat the cancer, and these cells still live, and then they form another tumor and it comes back. And the last thing that defines a tumor-initiating cell is the ability to move. And that's why I talked about metastasis, and why these cells are important for metastasis is because they like to move a lot. And so this graphic kind of sums it up here, is that I'm trying to identify how TICs function so that we can target them, and by targeting them plus the whole tumor, we can get the whole tumor to go away. And if we don't treat the tumor initiating cell, it just comes back. Next slide, please. So the problem with tumor initiating cells, or TICs, is that they're such a rare subpopulation, it makes it hard to study. So what we did is, in collaboration with another lab at the University of Michigan, we developed a device to enrich for these cells. And this device is based on migration. And that's because tumor initiating cells, as I mentioned before, are very good cells to move a lot, and we can get a bunch of them together, we will be able to study them. So the way that this works is you put cells in this device on the outside in the blue, and then you give them a stimulus to move in the middle where the red is, and then the cells will move to the middle, and then we can isolate them from the middle, and then we can do any type of experiment we want with them. Hit next, please. This is an image of the device for scale. It's pretty small. It's about the size of a couple pennies. I just think it's really cool how we can make cool things so small. I'm not an engineer, but that's really cool that we can do this. Next, please. And then this is just an image of the device as cells are moving through it. So the red is defining a tumor initiating cell or a highly migratory cell move through the device over time. And then the blue arrows are showing you a non-migratory cell or a not tumor initiating cell. Next, please. So with this device, we were able to get a bunch of TICs, and then we cracked them open essentially to figure out how they tick. We looked at their DNA and their RNA, and we found that this gene, PISD, also known as phosphatidylserine decarboxylase, that expression is actually significantly decreased in tumor-initiating cells. So a tumor-initiating cell does not express this gene. In addition to that, high expression of this gene is actually correlates with better patient prognosis. So if you have this gene, you're more likely to do better than somebody whose cancer doesn't express this gene at all. Next slide, please. So what we wanted to do is figure out if this is true in our case, and we took these TICs that didn't express this gene, and we put this gene back into them, and then we ended up finding out that when we put this gene back into them, these breast cancer cells don't form tumors as often, they don't grow as fast, and they don't metastasize as much. So this to us shows us that PISD is an important tumor suppressor, and maybe an important regulator of tumor-initiating cells. So if we can figure out how PISD does this, we can essentially stop cancer from moving. We can keep it in its primary spot, which makes the patient have a better prognosis. Next slide, please. So PISD is located within the mitochondria. And one of the things I always like to say is that you're probably told you that the mitochondria are the powerhouse of the cell. And yes, that is very true, but I want to tell you that it's so much more. The mitochondria are involved in every aspect of the cell. How it makes energy, how it moves, how it grows, all of that are due to mitochondria. And one of the more important things to know about the mitochondria is that they're dynamic. They shift how they look within the cell based on what is surrounding them, what is the environment. So they can be fused, like this green here, or they can be fragmented or dotty, like this red picture here. And they can switch between these two groups just based on what conditions the cell is in. Next slide, please. So because PISD is located within the mitochondria, we wanted to see, does the expression of this gene affect how the mitochondria look in cells? And we found that in 2 different triple negative breast cancer cells, when you put this gene back in, you dramatically change how the mitochondria look in these cells. So on the left of these 2 pictures, you see the letters WT, that stands for your control or your wild type. These cells, the mitochondria, which is what you're seeing here, are very, I like to say spaghetti-like. They're elongated. When you look on the right, these are cells, the exact same cells, but all they have different is now they have PISD. And you see these mitochondria are very dotty. So they're more like the red picture from the previous slide. So based on this alone, we know that PISD is doing something with the mitochondria, and that's leading to this decrease in the ability of these cells to form tumors, grow, and metastasize. Next slide, please. So what we next wanted to find out is, as I mentioned before, tumor-initiating cells are really good at migrating. So we wanted to see, if we put PISD in these cells, do we inhibit these cells from moving? Because if we can inhibit them from moving, then we likely have a very good opportunity to stop cancer from metastasizing, and maybe a mechanism for why they're not metastasizing. And what we ended up finding is that if you put PISD in these cells, as well as treat it with something that mimics PISD, you can see that it inhibits migration. So if you look at the green or the red in the middle of that graph on the right, you can see that they don't migrate as much compared to the wild type cells, or using a drug that promotes the opposite effect of PISD. Those cells migrate more. So what we found is that mitochondrial morphology and PISD are important for inhibiting triple negative breast cancer migration and metastasis. And right, that's the last slide that I have of data, but more or less, this is where the ACS has really stepped in and given me the funding to continue to do this work. And they're giving me the opportunity to try and figure out how this is happening so that we can develop drugs that will mimic PISD or change the mitochondria somehow in order to stop breast cancer from moving and stop it from metastasizing. Next slide. So I just wanted to take the time to thank all of the people that have been involved in my research in the Luker Lab, as well as people who in the past who have left to go on to do other amazing things, as well as our collaborators at the University of Michigan and abroad, or domestic. And I also wanted to take the time to say thank you to the American Cancer Society for funding me and believing in me and my work. Next slide. I think I have one more. Yes, and so this is just a quick summary. I always like to lead this up during questions in case there are questions about the science, but I am also willing to take questions about anything and everything science. If I don't have an answer, I will try my best. But yes, thank you for your time and listening to me, and hopefully I made sense. If you have any questions, you can always email me or get a hold of me, and I'm always willing to talk science. Thank you.
Well, I've received some questions already, Dr. Brock, ahead of time, and I'm going to go ahead and share some of these with you and give you time to respond, and we'll keep monitoring for new questions coming in. That was a fascinating conversation. I got much more out of that than I ever imagined I would. But here's our first question. We are realizing the consequences of our actions and cause and effect of industry and toxins in our environment. Lawsuits being won against the likes of Monsanto for glyphosate, and yet this stuff is still on the shelves of every home improvement store. What is the role of science, the science community, in mitigating the continued toxification of our planet, particularly since it's the chemical into being?
So that's a great question. I think within the scope of how society is now, I think scientists are, I mean, I don't want to get super political, but I think scientists are, we're not really at the forefront. People don't like to listen to us right now for some reason, and I don't know why. But I think the role of scientists and people who are interested in the environment is to, stand up for what you believe in. I mean, there's plenty of research out there saying that that Roundup is not great, but it's still out there. And I think there are other alternatives that work. But if you strongly believe in that, I say stand up for it and do what you need to do. We're, as scientists, we are always fighting for our passion. The reason we do this is because we love doing this, and we will keep fighting for it. So I think that same type of passion needs to be put forth towards something like that as well.
Okay, and I do have another question. This one is kind of similar. It says, headlines of magazines and many nutritional publications warn us of a need to change our diets, that obesity and simply the consumption of foods with sugar, alcohol, and the American diet in general, it's kind of helping to increase cancer in us. So along with our modern food production relying on GMOs and other environmental influences, what's the likelihood that we can really stem the tide against cancer without solutions that also come from industry and lawmakers? It's not just eat right to avoid cancer. What is the broader vision we can take away from your perspective as a scientist?
I mean, I talked a little bit about it earlier. Our diet it plays a very strong, or one of the very strong roles in cancer incidence. The processed foods and everything that we have on the shelves, the quick things, the easy things are the ones that seem to be the worst for us. And they always say eat in moderation. That's the way to go, which I believe as well. As I think moderation is important, but I think the bigger problem, as you say, is that people don't like change. People don't want to change. They think that since it's been working just fine, we'll just keep it on making more processed foods, and nobody's holding these people accountable. I think, my sentiments from the last question, if you believe in something, you should stand up there. You're not alone. You're never alone. There are always people that are out there willing to fight for the right. And I think it's the change is coming. I think this is a good way to say change is coming, and stand up for what you believe in and fight for it. I think just sitting back and saying, I'm going to eat right is maybe not, in my opinion, the best way to make change for the greater community as a greater whole.
Yeah. Okay. So now I have something that is more generic. What are the best ways to protect myself from getting breast cancer?
I think the best thing is mammograms. Obviously, that's the best thing, is make sure you keep getting your mammograms, because that has been shown to be the most effective way to identify, catch it early, and leads to a better prognosis. So that single-handedly is the best thing to do. A lot of times, your diet and other things aren't the only factors. I mean, genetics is an important factor. So there are things to think about, such as BRCA1 has been shown to lead to breast cancer in younger women. So make sure you can get that checked out. You can get a DNA test and get that checked out. But in addition to diet and stuff, I think genetics plays a huge role. So if you can identify these things early, it's going to be better for your outcome. Earlier is better, as they say.
Right. Okay, thank you. Jennifer, you had a question come in?
I did get a question that came in. So they're asking, what are your future plans with this research, Brock?
How much time do we got? No, I'm just kidding. There are a lot of different areas in which I'm looking to go into, but the direction that I'm looking at is I'm looking at how lipids in your cells, so fatty acids, these things that we get from our food, how those actually affect the mitochondria and how that affects cancer. So I think the direction that I'm moving forward into is how lipids affect mitochondria, and then how the mitochondria affect cancer. So it's kind of maybe leading into the whole diet thing, but that's the future direction that I'm looking into.
Another question is, how has COVID impacted your current research?
A lot. That's too long didn't read it, affects it a lot. As you can see, probably now I'm in my room at my house. I don't get to go in as often. I don't get to stay at work. We're only at 60% capacity right now. So for about 3 months, I wasn't even allowed to go into work. So this is, not even to think about the funding situation in the future. I think it's affected current lab work. It set us all back a little bit. And it will affect our funding in the future. So there will be less funding opportunity in the future for cancer research, I think. So now more than ever, I think fundraising and stuff like that is super important. I know I'm working with my family with our funding with the ACS we do Relay for Life, and we're trying to figure out the best way to fundraise, because we know it's very important. It's going to be very important for the future. And I would say wear a mask. I want to say that now. You should wear a mask if you can when you're out, because that's going to help make COVID go away faster.
So, Brock, I have a question. I'm trying to make sure I understood. So with breast cancer now, are you saying that most persons don't have to have the chemotherapy anymore? Is that what's happening?
So for triple negative, yes. For triple negative, the only course of therapy right now is drug-based, is chemotherapy. Other than that, they have radiation and surgery to remove it. But for the targeted therapies, for like luminal, they have a much better. They're less likely to have to go through some of the things they have to do for triple negative, because they have the targeted therapy, and it will shrink the tumor smaller, so that for example, the surgery site is smaller in these patients. So I'm sorry if I was confusing, but they still have it, but they have a better prognosis because they have such targeted therapies. They don't have the therapy that targets normal cells as well.
Okay. I just know that I'm a 10-year survivor, so my only choice was the chemotherapy and the mastectomy. So I'm just hearing that there's this new therapy now that is not as invasive.
Very much so. And in addition to that, the surgery I didn't talk about it, but the surgery and as well as the imaging techniques have also advanced. So my lab works in the Department of Radiology. So I hear a lot about new imaging techniques that are better than they used to be. So just the fact that we have, and our surgery is better, so that our surgery lines are smaller. So they used to take a huge swath of everything. Now they're much smaller now, because we have dyes or certain imaging reagents that will mark only tumor cells, so that our tumor margins are actually smaller too. So everything has gotten a lot better, and it's only going to get better, I think.
Good. That's great to know. Thank you.
Mm-hmm.
Okay, and I have another question. This sounds more like from a healthcare professional. Is there anything new in the detection of inflammatory breast cancer, as the symptomology is different than in other forms of breast cancer?
Yes, so that is a tricky question. I work with inflammatory breast cancer in the lab as well. It's tricky because although inflammatory breast cancer can be, classified as a triple negative breast cancer, it doesn't act like a normal triple negative breast cancer. So I know, based on some clinical parameters, that the inflammatory breast cancer can actually sit in you and not grow at all for months, years even, and then it'll get a sign. We still don't know what that sign is to start growing, and then it will take off. I don't think we know enough about inflammatory breast cancers that I can make a definitive statement. But I think it's something that is currently being reviewed, and I'm sorry I couldn't be more help than that.
Okay, and I have one comment that was came in to thank you, Dr. Brock, and the team for bringing such a wonderful presenter. Do we have any more questions?
I still have two. So the next question is what made you decide to be a cancer researcher?
That's a great question. So personal, it's a personal story. In 10th grade, my grandmother was diagnosed with leukemia, and on her deathbed, I promised her I would find the cure for cancer. So the reason I got into cancer research was so that people didn't have to watch their loved ones pass away on hospital beds. It's something that will stick with me. I still get emotional over it, and I just don't want that for anybody else. So that's why I got into cancer research. And I will say that I think the majority of people who do cancer research have a similar story. So it's personal for us. I think, we're in this, as a team, and I want to stop cancer.
Thank you. The next question is about stats, and they would like to ask you to provide any data about the differentiation between male and female breast cancer.
That's a great question. I don't have the stats on hand, but that person is correct that males also get breast cancer. It's about 2,000, I think, ish people a year, males a year get breast cancer. And believe it or not, majority of it is actually triple negative. So males are not immune to getting breast cancer. And they also need to take precautions as well as that. They can't get mammograms per se, but the males can still get breast cancer, and it's mostly triple negative. So they're not immune to it.
Okay, at this point, I have no more questions. Becky, did you get any?
No, I don't see any new questions. But I have an idea, and I think it's supported by the folks on our call today. We'd like to put out a challenge to Mott Community College to do a $5 donation. We know Dr. Brock has told us in the past at some of our gatherings that $5 keeps a cell alive in the lab for 1 week, right, Doctor?
Yes, I didn't get to say it, but yeah, my $5 can help keep my cells alive for a week, honestly. Okay. So it seems like a lot of people think that $5 doesn't do much, and you have to have huge donations, but really the small donations help just as much as the large ones. So yes.
So that's our challenge today. We want to challenge our Mott family to go online to the Making Strides Flint and scroll down to the end of the page and put in the team name for Mott Community College or your favorite walker. I just say, Jennifer and I were there. And whoever can, or you can sign yourself up, whoever raises the most money, we're going to give you some ACS swag, some cool stuff. Isn't that right?
Yes, I'm flashing them now. So here's a hat and a lunch tote that if you sign up and raise the most money, what did we say this week? Is that the deadline?
Should we do 24 hours? Let's really push it.
Yes, let's do the next 24 hours. So we'll just say 3 o'clock tomorrow. We'll do that. And and you can everyone loves an app, ACS fundraising app. You can download it and sign up and connect your Facebook and take credit card donations and check donations, especially in COVID when we can't come together in person. It's a great tool. But I want to also take this opportunity to thank Jennifer and Becky and Dr. Beverly and all MCC for being our hosts for our kind of virtual social distancing walk this past weekend, but also for your many years of being an important partner with the American Cancer Society. And thank you, Dr. Humphries. I always learn something new when you talk. You are amazing. Thank you so much.
Thank you.
I quite agree.
Well, Becky, I didn't get any more questions, so I think we're going to sign off. And I would like to also say the same thing Katie just did. Thank you, Dr. Humphries, for joining us today. I saw you 2 years ago, and you gave me that $5 piece of information that I have put on all my flyers for the last 2 years, so I can get you as many $5 donations to get those cells, to keep them alive. So I appreciate, again, all of your time and your effort that you have given to us today and our college community. And that's it. Thank you so very much. And thank you, Mott Community College, for allowing me to have this educational opportunity and present it.
Dr. Beverly wants to ask a question. Hang on.
Yes, I'm sorry. I do have one more question for you, Brock. I'm prolonging things, so I apologize.
Oh, no, absolutely. Let's talk science. I love it.
Right. So I wanted you to talk a little bit, diversity, equity, and inclusion is a top priority for our college. Mm-hmm. And so I'd really like for you to talk about African-American women and where are we with the science with them? Because it's a little different when you're looking at all females and African-American females and breast cancer and really the types of cancer that we get, but also the aggressiveness of it. So could you at least talk about that and what African-American women should be doing right now?
Yeah, so that's a great point. I think I didn't touch on it in my presentation, but yes, you can further break down the incidence and death rates of breast cancer into different races. And actually, African-American women, they actually have a higher percentage of cancer, but also a higher percentage of triple-negative breast cancer. They actually are more likely to get triple-negative breast cancer than any of the other races. I think it has a lot to do with genetics. I'm not 100% sure, but at least for that, and they're actually diagnosed younger too, which is it's crazy. What I don't know why, and I think it still baffles people, but people are looking into it. But I think the health equity research that's been going on, especially through the ACS and everything, is trying to address this and trying to offer more opportunities and give more opportunities to everyone, but to try and make that not a statistic that jumps out at you. They try to help them so that it's, I don't know if it's a great way to put it, but they don't want it to be crazy. They don't want it to be an anomaly. Like it should be not something that we're like, oh, wow, the African Americans are higher. I don't know why. We should be able to know why, treat it, get it better, and fix it. And I think the health equity research that's going on right now is really going to help address that. But I think the best thing to do is to continue to be healthy and get your checkups and that kind of that stuff for right now. But yes, it's true that.
Thank you, Brock, and you've done a wonderful job. I appreciate it.
Thank you so much for having me. And again, thank you everyone for listening. I probably talked your all ears off and you might be sick of me, but Thank you so much for having me here, and I'm always happy to talk science.
Thank you. Thanks everyone again. Really appreciate everything.
Thanks.
Have a great day.